subject which is keenly and eagerly followed by parents all over the world. Bharat MD Foundation is a parent advocacy organization committed to the well-being of patients and families in all aspects. Our main focus is on PMC, namely to ensure a holistic approach to prevent, manage, and facilitate research for a cure for this condition. It is indeed an honor to have with us a distinguished pediatric neurologist, Dr. Vivek Mundada. He is a British board certified consultant pediatric neurologist trained in India and the UK and currently works at the Medcare hospitals and centers in Dubai. Dr. Vivek completed his MBBS and DCH in India and thereafter went to UK for further subspeciality training in pediatric neurodisability and neurology and received CCT in this area. The Royal College of Paediatrics and Child Health, UK, has awarded him the MRCPCH and DCH degrees, as well as the prestigious fellowship FRCPCH. He has worked in several hospitals in the UK, and his work in the field of acquired brain injury in Royal London Hospital was acknowledged by the House of Lords, UK. Dr. Vivek is an active member of several professional associations, including the British Pediatric Neurology Association, the European Pediatric Neurology Society, the International Child Neurology Association, the British Academy of Childhood Disability, the Indian Association of Pediatrics, to name a few. With his initiative, 2 of the spinal muscular atrophy children received gene therapy for the first time in the UAE in November 2020. Till date, many infants with this condition from countries like Iran, Turkey, Romania, Nepal, and Ethiopia have received successful gene therapy under his care. Apart from the complex pediatric epilepsies and neurodevelopmental disorders, his areas of special interest lie in childhood headaches and pediatric movement disorder. Dr. Vivek's training and experience makes him highly qualified to treat complex neurological conditions in children, such as complex epilepsy, neuromuscular disorders, neurodevelopmental disorders, and so on. In addition to his work as a medical specialist, he loves to sing and is formally trained in Indian classical music. He has been actively involved in teaching students and nurses at different hospitals and medical colleges in the UK and India. He also loves reading, literature, and traveling. We are grateful to you, Dr. Vivek, for sparing your valuable time from your busy schedule to address the concerns of parents who have joined from different parts of the world on a topic of crucial importance. A humble request to all viewers, kindly mute your audios and turn off your videos for a smooth transition. Please note relevant questions on the subject at the time of registration will be taken up first, and if time permits, you may post your questions in the chat. Please confine all your questions to the subject discussed today. Specific individual case history or repetitive questions shall not be taken up. Over to you, Dr. Vivek.
Thank you. Thank you for the kind introduction, and thank you for inviting me for today evening. I received a set of questions, and what I thought is I'll just give a brief presentation just about the gene therapy mainly, because I'm sure everybody here knows what DMD is and the genetics and all. So I'm not going to go detail about this condition, but briefly we'll just discuss about the new era of this therapy. Can everybody see this the screen?
Yes, doctor.
Okay.
Yeah.
Because we're just focusing on this new therapy, gene therapy for Duchenne muscular dystrophy. And as I said, I'm not going to go detail about the condition. I hope this presentation covers kind of a lot of your questions which I received, and those which are not covered, then we can answer that later. Okay. The outlook of today's talk would be just the basics of what gene therapy is, what are the risks and benefit of this. How, in the real world, what do we do? What are the logistics involved in the gene therapy? And then, as I said, we'll do the question answer in the end. So, if I can go in a bit of a scientific the way about what gene is. So, if you know your biology lesson, the body is made up of cell. There is a nucleus in the center, and the gene is what is on the top, which is like a DNA. If you see the top of this thing, let me just show this. So this part is the gene, and what happens is the gene gives the instruction to produce the protein, and there is a step involved which is called transcription. And this causes the production of something called mRNA. And from mRNA to the protein production is called translation. And there is a protein, if you see the chain, because all the small lines which are there on the DNA are responsible to give rise to a kind of constituents of protein called amino acid, and a chain of amino acid is called protein. And when this protein is formed in raw form, it gets compacted and modulated to become a functional protein. So this is what happens in a normal individual inside the cell when you get the protein production from the DNA. So it's like a two-steps production. And there are drugs which then work at certain levels. So for example, if you have any problem in the transcription, so there are drugs which can act on this level, such as exon skipping. All of you might have heard about exon skipping. So they are the disruption of expression processing. So these drugs work at this level. Or if you have heard spinal muscular atrophy, splicing modulations like new diplom, which eventually allows the molecule to produce the DNA to produce the protein. Because there are drugs which are working at the transcription level, and one of the commonest example is something called the atolurine, or which works at the nonsense mutation. So what is gene therapy? So we have these drugs in existing, but what about the gene therapy? So let me just clear this part. Okay. So now we are in the era of gene therapy. So what happens is we're actually replacing what is missing in the body. So all of you know that the DMD has a missing DMD gene, and we need to introduce that gene inside the body. So how do we do that? Because you cannot just inject the gene like that. You have to have a vector, kind of a body in which the gene can be inserted. And this is a virus. If you see the number 1 is a virus called adeno-associated virus. What they do is take the genome of the virus out and introduce a gene inside the virus. The virus then goes inside the cell. Okay, sorry. And it goes inside the shell. Virus bursts open. It introduces the gene introduced in the virus from outside, and that gene then start producing the protein. So this is the simplest way how we can explain what is gene therapy. Is a vector, it goes inside the cell. The virus has a property of infecting the cell. So infecting means it goes inside the cell, the virus shell bursts open, the gene goes inside the cell, it uses the machinery of the cell to start producing the protein. And this is what we have been using in different gene therapies, including spinal muscular atrophy and recently Duchenne muscular dystrophy. However, the problem with AAV virus that we have is, I don't know if you know that the dystrophin or DMD gene is a very big gene. So the full length of DMD gene is around 2.2 megabyte, whereas the fully processed DMD gene is 14 kilobyte. And any AAV, so the virus is very small particle, it has to go inside the cell. So it's smaller than the virus, the cell. So the AAV can only hold 4.7 kilobyte of the genetic material. So all we have to do is we cannot introduce that the fully functional DMD gene. So what the scientists have done, they have created a smaller gene called microdystrophin, but it's a functional, you have heard the Bakers and Duchenne. So it's a functional gene, but a smaller version, the smaller, kilobyte, so that it can be inserted in the virus. And that's what the mechanism of microdystrophin. Unfortunately, DMD is a very big gene with 79 exons, and it cannot be inserted in any vector. So they had to do this by introducing this smaller version. And the different companies have taken the different approaches. Different researchers have introduced different microdystrophin. For example, if you see on the top, it's a full-length dystrophin, whereas the Pfizer has made this one. They are using AAV9, the virus, and inside they are introducing this gene. Whereas Sarepta, which is now commercially available, they're using the AAV RH74. These are the virus names, of course. The full form of AAV is adeno-associated virus. This is the microdystrophin which Sarepta has used, and there are other companies which are working on that, and the trial going on at the moment with different gene therapies. But Sarepta has come up with the first gene therapy which was introduced late last year. And this is what a microdystrophin looks like. If you look at the left. So there are different component of that gene. So the first one is called promoter. Promoter is someone, which starts producing. You have to give instruction to the cell. Okay, start producing the protein. Then there's a functional part in the middle where it says, this is the functional dystrophin which is going to produce. And in the end, you have to have somewhere to stop. Otherwise the protein will start producing. So there's a stop codon as well. If you see the expression MHCK7 at the bottom of expression, this is a specific gene they have introduced so that the expression of the gene in the heart muscle is also there. And that is why, it's a kind of a functional gene in its way. How do we know this is working? So there are different studies that they have done before introducing this drug in the commercial market. And the first of all study was done on the 4 patients to see the side effects, to see what is the dosing, and if the gene gets expressed in the cells or not, in the muscle cell. And it's called that study 101. So the primary outcome was to check the safety of the drug, to see the side effects, and the additional input was, whether this microdystrophin gets introduced in the muscle. How do we do that? You take the biopsy of the muscle, check under the microscope, and see if the protein is produced. So all of you know that the dystrophin is very important protein in the muscle cell. It's like an anchor which makes the muscle stable. And they have checked in those patients if the dystrophin is introduced in the muscle cells or not. So they have done the muscle biopsy, and the age group was, between 4 to 8. There were just 4 children. Muscle biopsy was there. And then there's a long-term follow-up involved in this. And we have the data for 4 years on these children now. So what we know now, you see the column is for 4 patients, and there's a mean. So there's kind of a average of all the 4 patients on the rightmost column. So the average age, is around 9.2. It's at the follow-up actually. And now the score, I'm sure you know the North Star assessment score. So there's increment, and there is a, that score has stayed for that for long in the 4 years review, up to 7 points increment in the North Star assessment score. And there's a significant decrease in all the time test, time to rise, 4-stair climb, the 100-meter walking, 100-meter run, all these things have, if minus means there is a positive, just because the time has become less after the gene therapy. And the most significant one was North Star assessment score, which has sustainedly remained at 7 point even after the 4 years, review after the gene therapy. Now there's a different the study called 102 study. And what it looks is more of, the stabilization of the motor function, which was observed up to 2 years following the treatment. And there was a kind of a favorable benefit to risk ratio for that. Now, they had the 2 cohorts, 2 to 5 years and 6 to 7 years. Now, if you see the increase in the North Star assessment, it was more significant in 2 to 5 years, okay? So if I just explain you what p-value means, so less is the p-value, less than 0.005, more is the significant of the studies, what they call significance. So if you see the treated group on the top, so delandistrogene moxeparvovec is the name of this Elevidys. So this group had the change, the North Star assessment change was very significant in this group. And this is why initially when the drug came to market, it had a label to be used in the 4 to 5 years only, and it was not allowed, it wasn't that much significant. That was not that much beneficial in the old age group. That's what they thought in this age, that study. And that is why the FDA had approved for 4 to 5 years. Now, what happened? There were more studies called Endeavor study, and further on, last year, if you remember, there was an Embark study as well. So what this Endeavor study was is a first clinical study to be, for the drug to come into commercial market. And there was a good evidence supporting improved motor function following the treatment with Elevidys, okay, when it was given at those ages. And the safety profile was also checked, and it was very consistent with that of the previous studies. There were no any extra side effects. So if you see the top most figures, this is something called a baseline, and if you see the middle one, dystrophin, which is a brown or maroon color, there is no dystrophin in the check patient. But when you give the gene therapy on the in the middle, in the bottom, if you see, there is an expression of the dystrophin. So this is the biopsy of the muscle. So after giving the gene therapy, the muscle have started producing the dystrophin, and this is why this study was significant there. And latest, there was an EMBARK study, which was a global randomized, double-blinded, placebo control. I'm not going to go into detail what these meanings of these the words are. And it's a phase 3 clinical trial, and this was studied between the age of 4 to 7 years. If you know, if all of you must have heard the news that, it didn't meet the primary endpoint because the point increase, all the patient improved by 2.6 points on their North Star assessment after 1 year. And that was not statistically significant. If you remember that p-value I was showing, it was not less than 0.005. And it failed on that. But what was important in this study, the time to rise, if you pass that more than 5 seconds, that is a kind of indicator that there's a loss of ambulation is going to follow in the children. But what this elevators did in EMBARK study is reduce those odds over 1 year, but more than 90%. So if you see that loss of ambulation was highly kind of, avoided in this group of the children who were treated. And this was what was taken up by the FDA. And afterwards, there was the approval of this drug to be used in the older children as well, based on this. Although it failed the primary endpoint, but there was more of a clinical significance was seen in the elevators, which they thought that, this drug is going to be beneficial in DMD, and that's why they allowed to be used in the older population. And if we accumulate all the data, all the study together, and this is what we get. Now, the first one is the North Star assessment. If you see, the blue color is the treated group and the yellow color is the untreated group. So with the period of time, North Star assessment score goes down. And this is why it was in the minus, if you see the yellow. But in the treated group, it has gone up. And if you see the statistical value above, this P is 0.0001. It's highly significant. This is why, okay? Is your time to rise. Again, if you see in the treated group, it has gone down significantly. Progressively, it gets worse in the untreated group. Again, the p-value is very significant. Not so in the 10-minute walking the test, the p-value is not that significant, but still, if you see the significant difference, because this patient get deteriorated in untreated, whereas there is a progress in the treated group, as you can see. So this is just to take home from all the research studies what we have seen. So it's like a data of around 52 patients, which they have cumulatively expressed here in the graph. Now, there were many questions about what are the side effects of this study. So if you see all this research patient of 84, the number, so 7 out of these 84 has experienced some kind of side effect, which is not significant, around 8.3%. And they were vomiting in 2 patients, increased liver enzyme was seen in 2 patients, rhabdomyolysis, which is like a muscle breakdown or muscle affection in 2 patients. There was a liver injury more serious than just rising the enzyme in 1. Immune-mediated myositis, which is like, again, the muscle, get affected because of the drug itself, which was seen in 1, and myocarditis, which is the affection of the heart. Now, the reason which I made it bold, the immune-mediated myositis and myocarditis, which was seen in the patients who had exon 8 and 9 mutation, and this is where the drug is not being used currently in these children. We have deletion on 8 or 9 because of this reason. So most common side effects. Now, recently what happened is when they started using the drug in US, some of the children started having allergic reaction to that, even the anaphylaxis. So they had to stop the infusion, the antihistamine drug, and stop this anaphylaxis. So that is something known. So we always start the drug at very low rate, make sure the child is not. Before giving the drug, we will not know if the child is allergic to that or not. It is only during the infusion we will know. Liver injury, as I was saying, is very commonly observed in any gene therapy. And it results in the elevation of liver enzyme, which is typically seen within 2 months after giving the gene therapy. And this is where we monitor the children even after the gene therapy. Now, in the clinical trials, immune-mediated myositis, as I was just telling in the slide before, was observed approximately 1 month after the infusion, and they were observed in the children who had deletion in exon 8 and 9. And symptoms of this myositis. Myo is muscle, sitis is inflammation. So myositis, which causes severe muscle weakness, even the swallow muscles get affected, causing dysphagia. The breathing muscles get affected, causing breathlessness, and also the voice gets affected. So all these symptoms were so severe that they had to withdraw the indication for these children. There's a limited data for those who have the mutation in exon 1 to 17 or 59 to 71. And patient with the deletion, they say theoretically, they have a more risk of having this immune-mediated myositis, but there's no kind of a clinical backup data to prove that kind of thing. Myocarditis, which is affection of the heart muscle, and this enzyme called troponin I, which is linked to the myocardium or the heart muscle. If you have the injury to myocardium, this enzyme goes up, and we always check that. So elevation of this enzyme has been observed after this infusion. Now, this AAV virus in which the functional gene is introduced, they itself can cause the problem in the allergic or immune-mediated reaction. And we need to make sure that there is no antibody in the blood. Because see, what will happen is if you have an antibody against the virus, before going into the cell, the antibody will kill the virus and the gene will be ineffective. And this is why we need to check the antibodies. If you have the antibodies in the blood, we cannot give the gene therapy because, the virus will be ineffective. The antibodies will start killing the virus itself. And the most common reaction, the myocarditis, liver enzyme, we don't see that commonly, but the most commonly seen, again, in more than 5% of the population, were vomiting, nausea, liver injury, the fever, and low platelet count. And these were the most commonly seen, the side effects there. So this is how the box looks like. The gene therapy on the bottom comes from US, manufactured by Sarepta. And the label at the moment in today's time is indicated for the treatment of Duchenne muscular dystrophy in individuals at least 4 years of age. So there's a minimum cutoff of 4 years. There's no upper cutoff at the moment because of the reason I mentioned from the research studies. And those who are ambulatory have a confirmed mutation in DMD gene. And those who are non-ambulatory and confirmed mutation. So basically, if you combine these things, so anybody above 4 years, irrespective of their ambulation status, can get the gene therapy. However, you cannot give that if the patient has any deletion, not duplication. Duplication you can use, but deletion in exon 8 and or 9 in the DMD gene. And of course, if you have antibodies against AAV, RH74, then also you cannot use that, the gene therapy. Now, all of you have asked about the risk and the benefit. I'm not going to go in the debate about the cost of the medication and all, but of course, all the risk which is involved, all of the side effect which you have seen is related to the immune response of the body. Anything foreign substance goes in the body produces immune response. As simple as flu virus, it goes and you get the antibodies. And the response may be to viral vector, so the virus which is, AAV RH74, or the gene product which you have introduced inside. So the body can also produce the allergic reaction to that or immune reaction to that. And how do we minimize that risk is by giving the steroid. Steroids are well-known, anti-inflammatory or anti-immune substance. And that is why all the children who receive the gene therapy have the steroid. Even if the child is on the steroid for DMD, we have to give added steroid during the period of the gene therapy. Now, coming to the real world, what we are doing here in Medcare Women and Children Hospital in Dubai, we started our gene therapy journey back in November 2020 under the program called GMAP program. I had 2 patients with SMA, and both had the gene therapy in November 2020. And this is where our journey was started. We set up our multidisciplinary team. We have learned a lot through our experience, how the gene therapy works, what are the requirements, what are the patient's requirement, the clinical work, and so on. There's a lot of research and publications have gone since then. Recently, in April 2024, we have celebrated our 100th patient in SMA. Of course, the gene therapy for the Duchenne muscular dystrophy came quite late last year. And we started introducing because the company chose us because of our experience in the spinal muscular atrophy. So we're the only private hospitals in Dubai, whereas government hospital, of course, they are giving it, but the only private hospital in the region, and probably outside, the only private hospital outside US because of the experience in spinal muscular atrophy. We have given more than 130 spinal muscular atrophy gene therapy, and the third infusion of Elevidys will happen just in 2 to 3 days time. This is the news which you see is our second patient actually who came from Turkey, and the third one is ready for the infusion. The drug is on the way, and we'll be infusing the third patient soon. So what do we do? How do we do it here? So first of all, there is an assessment of eligibility. Some of you, or if you know the way, because if you put the query to us, we give the questionnaire to refill, the medical reports request, the physiotherapy, the genetic test reports, everything comes. If needed, there is a Zoom call set up. We assess the eligibility if the child is suitable or not. And it happens more so in the spinal muscular atrophy because these children are more complex compared to the DMD children. Then after the fundraising is complete, or if the parents have enough funds to come here to Dubai and purchase the drug, they then come to Dubai. That fund is transferred upfront because the company takes the full payment for the drug. The logistic help is given to all the parents. There's a dedicated team of, which work for gene therapy patients, made before visa or accommodation, all sort of assistance, including the transport, everything is given here from the hotel to hospital and vice versa. Assessment is done because what we have seen through our SMA gene therapy experience is not all children. So all of you know there is a standard of care for this DMD children. It's easily available on website like Treat NMD, and we have to strictly follow that even after the gene therapy, because you're not correcting or reversing what has already gone as a damage. So we have to strictly follow the standard of care, and that comes only with the multidisciplinary assessment. All of you know there's an orthopedician, endocrinologist, cardiologist, pulmonologist, and these children are seen by our team here because many of the children have the lacunae in their care, and we don't want these children to go back or have any miss. So just to give a brief example, we had some children who came, very nicely looking children, and when we did the sleep study, we realized that the children actually need BiPAP in the sleep. So we had to convince the parents and set up the BiPAP for them. There were a few children who needed tracheostomy, gastrostomy after they came here because that was a priority even before going the gene therapy. And we had to do that to stabilize the children even before. So the bottom line is the child has to be stable enough to go for the gene therapy. So that is the reason why these children get assessed by the multidisciplinary team. And that includes even the functional scoring by the physiotherapist, all the scoring times test, upper limb test, and the NAS score and all. Any necessary or missing investigations we do, including like sleep study or bone density scan and so on. And then followed by laboratory workup, including the AAVrh74 antibodies. And for SMA, it's a different AAV9 antibodies, of course. This is again to check for the eligibility. The children get admitted for gene therapy. We usually admit for at least one night, depending on, if the clinical need is more, then they stay more, but minimum one night they stay in the PICU. We start the steroid as per the protocol. There's a different regime for DMD, different regime for SMA. I'll just briefly tell that later. And the monitoring post-therapy is very, very important. It's not just infusion and go home, because we need to make sure there is no side effect. We need to make sure there is no liver injury, no heart injury. And that's why these children get, weekly blood test to monitor the side effects. There is an adjustment of the dose. There is an introduction of the new medicine if the liver enzymes are too high. And of course, while they are here, they get the physiotherapy and other necessary input, clinical input during their stay. So on an average, around 3 to 4 months, they stay in Dubai. And once we start kind of cut down the steroid or stop the steroid, and if I think that the children are stable enough to go back, that's when we discharge them back to the country if they are traveling, of course, from outside Dubai. Coming back to Elevidys, some practical points. I've just given the general idea about what happens in the country when they come. So after the MDT assessment and negative anti-AAV Rh74 antibodies, we then order the drug. Steroids, now there are different regimes. So if somebody is already on the steroid, we start one day before if they are on the baseline steroid. If somebody is not on steroid, we have to start on 1 week before. The dose is different as well. And the same dose of steroid, we continue for 2 months, because, the many of the side effects can come later, by 8 weeks. And that is why I don't reduce the steroid before 2 months. And then afterwards, if things are stable, if the child is asymptomatic, then gradually there is a cut down to steroid and the child is left back to whatever the steroid he or she is for DMD. So the actual infusion is for it's a one-off infusion which goes for 1 to 2 hours, depending on the dose. The dose is dependent on the weight of the child. Um, Not to forget, I showed the figure where the virus kind of breaks down, to release the drug. So that broken products, the viral shedding, goes through the stool. So you have to wash the hands when you're coming into contact with the urine and stool, because what happens is if you introduce that viral shedding to somebody in the family, let's say somebody who has DMD, that person will start producing the antibody, and that is why they will become ineligible after that. So just to avoid that contamination of the virus to somebody else, we have to be very strict with the hygiene. Of course, as I said, we do the weekly bloods and clinic visit, and the functional scoring at the moment we're doing monthly. So as I said, we have infused 2 children by now, and the third one is this week later. So we have done the monthly score just to see how the improvement has been in these children, and that is why it's very important to objectively analyze these children compared to the subjective what parent reported feedback is. In some children, what we have seen is prolonged and long-term steroids may be necessary. Depends on the side effect, depends on how the child responds and so on. And it's very kind of subjective. So I've just given the brief overview of what happens and how the drug is given in a clinical setting. Okay, and I think that's all from my end, and I'll just take up the question if you have any.
Thank you, doctor. That was very, very informative for all of us. I have a few questions which parents have sent to us at the time of registering for this webinar. I'll just take one by one. The
Sure.
first one is assuming that all parameters are the same and only the antibodies are high. So how do we address this issue? Do we bring the antibodies level low, and will steroid dosage be upped in such cases?
Unfortunately, no. I mean, I get this question asked by many parents. See, what happens is, if I have a newborn baby with these antibodies, the likelihood of these antibodies in the newborn baby is mother has it, and during the delivery, she passes on to the newborn. That is the only scenario where you have the chances of having these antibodies, washed away. But in older children, once you produce the antibodies, it's very, very unlikely that they will wash away, and unfortunately they become ineligible. In my experience, we have done that for parent satisfaction. We have rechecked the antibodies after 6 months and so, but they have consistently been positive. And I'm talking about SMA, and I don't think that's very different in the DMD as well. So unless the child is newborn, but we don't know at birth unless we have the family history for DMD, and then we can check it very early. But in older children, it's very unlikely, unfortunately.
So similarly, with children having high levels of troponin, there's a greater risk of them having issues. So what is how will it impact the children, and are they going to be eligible for it? And even if they're in the initial stages of cardiomyopathy also, will the children be eligible for the gene therapy?
So troponin I is a good indicator rather than troponin T of myocardial injury. If already the child has liver issues, if the child has, myocarditis like issue, it becomes very tricky and difficult to give the gene therapy, because you then don't know where the things will go bonkers after the gene therapy, because already the child is at risk of having this side effect. And we don't want to introduce that risk. So far, luckily, because, if the label is for 4 to 5, in the older children, you may have it. And that's why we have to scrutinize the children and, carefully select the population. But I had one child recently who had a high liver enzyme, and luckily it turned out to be a infection related, and they settled after treating the infection. Younger children, the troponin I is not very significant. We don't see the myocardial injury, especially less than 1 year or so. I don't even bother if my troponin I is higher. But yes, it depends, because the cardiologist then assess the children. They'll make sure all these children get the MRI of the heart just to make sure there's no fibrosis, myocarditis as such. But again, it's tricky and very difficult to give gene therapy in these children.
Thank you, doctor. Will the gene therapy be applicable to both in-frame and out-of-frame mutations?
Yes. As I said, the only contraindication is deletion in 8 or 9, but otherwise everybody can have it.
So approximately for how much time the progression will be prolonged after the infusion?
See, the problem is we still have the research data for up to 8 years of children. And if I showed you the 101 data is after 4 years, and there's a sustained rise. So there are two things. One is the maintenance of the skill, and there's a slight improvement in their NAS score, which we have seen, and the time score I've shown in that graph as well. So there's no long-term study as such. We still have 4 to 5 years of data, which is still promising. There's a sustained rise in the North Star, which you don't see in the control population, of course. So, the time will tell how long and all, but in the current times, at least, there is a gradual rise in these functional scores. And of course, the expression of the gene in the muscles.
Thank you. And is the optimal infusion dosage based on age or dependent on the number of exons that have been deleted or mutated?
No,
Is that
the weight. The dose is based on the weight. Good question. But yeah, it's a weight. Nothing to do with the mutation or anything. It's a number of vials. If I tell you the number of vials is equivalent to the kg the child is. So 3 kg has 3 vials and so on.
okay? So if your child is obese or somebody, then you need more greater dosage.
Yes, that's right.
Thank you. So if a child receives gene therapy, what will be the future clinical trial opportunities and treatment options for them?
A good question. I mean, see, in coming from SMA, we still are very new for elevators. Many parents have asked, what if we do the dual therapy and so on? The mechanism of action is different. Same happens with SMA, the dual therapy, added therapy. Now there's an interest. What if we give in SMA, I'm telling, intrathecally, direct, very close to the target cells. Again, there are, if you know, there's a second generation antisense nucleotide coming up. There's a small molecule which they are coming up in DMD. So there are loads of research is still happening. There are other companies who are interested in the gene therapy. Pfizer unfortunately stopped the trial last month. I don't know the update recently. Hopefully they'll start soon. But many companies, I showed that picture how microdystrophin is produced by different companies. So I think the whole focus at the moment is the long-term data. The main important thing in the clinical I'm interested to see is how it works in the older children. Now, the next child which I'm infusing is nearly 4 years old now. When he's turning 4, I'll give. But the first one which I gave was around 7 years of age. So, so far he's doing good. But what I want to see is, because the label is in non-ambulatory population, I really don't know how much and what it will do. Will it just maintain the function and so on? So I think we'll have to wait and watch, this space to get those answers.
Thank you. We understand that exon deletion 8 and 9 are not amenable for gene therapy. So what are the options for these children? And what can the parents do?
Back to, what they are doing, in terms of steroid and multidisciplinary care. Unfortunately, in today's time, at least, there is no, if tomorrow there is another gene therapy coming, then, that's fine. There are synthetic steroids at the moment, which are not available in India or UAE, but, soon they will hit the market. But hopefully, the the new era will bring us more kind of options to give to these children. But Elevidys, no. And I'm just talking about Elevidys. The other gene therapy, hopefully, if they come in 1 or 2 years, maybe they are eligible for that.
Is gene therapy applicable to kids above 8 years having homozygous deletions of exons 46 to 51?
Yeah, anybody above 4 years is available except for 8 and 9 deletion.
Okay. What are the other clinical studies going on in gene therapy that you mentioned? You said couple of them are there or in the pipeline. If you say in a couple of years, maybe something can come up.
That's right. That's right. There's a second generation antisense oligonucleotide, all this exon skipping medication. Hopefully, we'll see that. There's a small molecule study which acts specifically on the muscles. Currently, one study is on hold. Pfizer hopefully will continue, because we were hopeful that Pfizer will introduce the gene therapy next year. They approached us as well, but the phase 3 trial is on hold at the moment because of the side effect, and they're reviewing that data. So I'm hoping that more product will come in the market soon in next 5-10 years.
When you say monitoring post infusion, so what kind of monitoring is required and how many specialist doctors are involved in the team?
So it all depends on the child's personal clinical care needs, if the what all the input. So usually before the gene therapy itself, we do all the screening. So they don't need all the doctors except for, ongoing physiotherapy. We do twice a week physiotherapy, at least we do. But weekly blood tests are must to check for the evidence of myocarditis or liver injury or other side effects. That is something we do. And the functional scoring improve, because that is of my interest to see, how the child is progressing. So mainly the side effect monitoring, and then accordingly we adjust the dose of the steroid. There are some children who need extra medication, steroid sparing. If the steroid is not controlling the side effect, we have to, because hepatologist is one of the important person, and cardiologist. If they have the sign of liver injury, then they go to hepatologist. If they have myocarditis, they go to cardiologist, and so on.
Okay, but if you up the steroids, what will its effect be on the bone density? Do they need frequent
Well,
DEXA scans?
It's not long term. It's not long term. Once the values start going down, then I start cutting down. So believe me, the SMA children, on an average, they stay on steroid for 3 to 4 months, not more than that. And same is the story for DMD. Of course, because we don't start cutting down the medicine steroid dose till 2 months. That is the only reason they are on this high dose steroid for 2 months. But after that, if the values are good, we start cutting down the steroid and leave them back to the whatever deflazacort or steroid they are on.
Is it possible to have a combination therapy like gene therapy and exon skipping at the same time?
Well, theoretically, yes, because the answer to that is, honestly, I don't know the answer, because we don't know what to happen. So after the gene therapy, if you have that added. But one of the good thing about exon skipping is some of the children who have come to my door to get the assessment, like a 12-year-old, 13-year-old, and if they are on exon skipping, they're extremely stable, their functional score is really good. Coming from the SMA data, I believe the mechanism of action is very different, the gene therapy and all. So I see no kind of contraindication to have that, if the parents want to continue that. One of the reasons why parents come for gene therapy to me is to stop that, weekly or, Spinraza 4-monthly injection. And it's costly as well if you see the cost. But if they can afford, if they can take, I see no reason why not. But we don't know the answer, at the moment, unless we have the clinical experience.
And if gene therapy is expanded to non-ambulatory children and young adults, so how will you check its efficacy, and what is the scoring mechanism that you will be observing?
So there are different scores in non-ambulatory, EK2 and other scores which we use. As I said, we haven't given so far in non-ambulatory, but this is something of my interest as well. So far, we have only given in ambulatory. The expansion of level was only end of June, 1 month before only, I think. So, we are yet to have this patient. There are many adult inquiries are coming. We are training our, adult neurologists at the moment. We're expanding that because there are a lot of inquiries coming. But there's no research experience in, let's say, 18-year-old or 20-year-old at the moment. And time will tell based on the clinical experience. But yeah, their monitoring is very different than the ambulatory. We don't use North Star in them. So there's a different functional scoring for them.
So how long should one wait to know the efficacy of gene therapy generally?
I think, once we have now, as I said, there's a 4 to 5 years of data, but tomorrow we want to know the long-term data. So like SMA, we have 8 to 9 years of data, but we don't have like years of data. So every time we'll have our benchmark or, goalpost set at a different level. So at the moment, we'll have to rely on what is existing available evidence at the moment. And based on that, we are using, the clinical experience. So I don't know. Tomorrow we might have 10 years experience and we'll get more knowledge, more number of patients, and we'll get more idea about it. But unfortunately, as I said, I'll have to rely on the research experience and a bit of a clinical experience, which is coming from US. We will be publishing our data soon with the 3 patient, but it's very less, 3 patient is not that big number, but hopefully time will tell.
Thank you, doctor. Then which will be more effective, you think, gene transfer or gene editing?
At the moment, we're not doing this, in vivo kind of a gene therapy for the patient. There are some conditions like metachromatic leukodystrophy or adenoleukodystrophy, where you have different mechanism of gene therapy. You just take the patient's cell out and do the editing and then send it back. We're not using that approach in DMD. We're using the gene therapy, which is now vector-based or viral-based. So I don't think there's any trial going on for editing at the moment.
Suppose gene therapy succeeds, can it be expanded to other forms of muscular dystrophy like LGMD?
See, the whole principle of gene therapy is you should be able to introduce a gene inside a virus, and that virus has to be capable to introduce inside the cell. If you can produce that recombinant gene in lab from human, whatever the cells, like they're using kidney cells for Zolgensma and all, then it's possible. But unfortunately, not all genes are stable, not all genes are capable enough to go inside the virus, because you need some vector to introduce a gene inside the body. And that is the biggest challenge, you know. So that's why there are different approaches like MLD, adrenal dystrophy. You can do that approach like a stem cell, but unfortunately, very limited condition you can go for gene therapy. Of course, there's a clinical trial for this condition going on, but again, watch the space and time will tell.
There are some children who have multiple disabilities like DMD, autism, and other this one. So will they be eligible because they may not be able to express or say anything? So how does it work in those children?
It's fine. We do monitor the side effect on the blood test. It's not that they have to tell. Of course, if somebody is in pain, the parents will know or we will know. Like myositis, they can cause the pain and so on. But there's no contraindication if they have comorbidity, speech problem, autism, or hyper ADHD kind of thing, because we know DMD has all this comorbidity, but at the moment there is no contraindication for that. It's very clinical how we monitor the blood test and so on.
Yeah. And slightly deviating from the subject, how would you think that parent advocacy organizations can move ahead in creating awareness or sharing knowledge among interested doctors across a vast country like India?
See, I think the major issue is early diagnosis. I have very few children who the doctor has picked, oh, there's a high liver enzyme without any liver injury. Why is that? Or CK is of so cheap taste. If somebody has a difficulty tiptoe walking and the doctor I've seen, they're reassuring, take vitamin D, leave it for some time, nothing will happen. The child will learn to walk properly. Imagine a 4-year-old is struggling to climb a stair. I would question myself why. I have asked that question. And recently, I had an Indian parent, and they said the diagnosis was like 9 years or so. And I said, what happened? That by 3-4 years, he was struggling. And I would ask that question myself: why a 4-year-old will struggle to run, struggle to climb a stairs? And CK is such a cheap test. That's the first thing to do. Of course, there are clinical signs like calf hypertrophy and pseudohypertrophy and so on. But that kind of awareness is very, very important for early diagnosis, because the gene therapy experience is earlier you give the therapy, better is the result. Believe me, if I have a child whom I can give pre-symptomatic, they will never develop the signs. And that is my experience from SMA. I've given gene therapy to 4 months and 5 months, and these children are developing like a normal children without any sign. So that's why early diagnosis, that's one thing. Secondly, all parents should go on the Treat NMD website. They should download the care plan or the house standard of care. It's available in different languages, Punjabi and Hindi and so on, in English also. And they should follow it like a Bible, because recently again, I met a parent from Mumbai, affluent family, but they have not started steroid, assuming there will be side effect, because again, the parents speak to each other. No two children are similar. They, have to risk the way the risk versus benefit. The child did not have lung function test. The child was 13-year-old, was not started on cardioprotective, the drug like ACE inhibitor. These are simple steps. You cannot skip those things. The standard of care has to be followed religiously. When to do bone density scan, monitoring scoliosis and hip and orthotics and physio. It's a job of multidisciplinary team, and you cannot replace that. I think the gene therapy is just a milestone inside that MDT, but you cannot take away the MDT care, or you cannot replace that. So that is something I think it's a major awareness in the diagnosed population, and of course the pediatric population to diagnose earlier.
So there's one parent who's asked a specific question in the chat who says that the child is 2.5 years old with a deletion in 45 and 52 exons, and want to know which pathogenic therapy is best, whether it is Viltespo or Elvidis, which should be better, where should they approach, and
They both have a different mechanism of action. If you can start with exon skipping, if the child is eligible, that's the best thing, because 2.5-year cannot receive LVDs at the moment, and they're not symptomatic also. If you are able to give the child gene therapy by 4 years, that's when they have mild symptom. It's one-off thing, it's done and dusted. You don't have to go for ongoing exon skipping. But as I said, there are some children, if they're eligible for exon skipping, why not? Till then they can get. But of course, you have to consider the cost of all the medication, the weekly injection, plus LVDs. And so you still have time, 1.5 years to give LVDs. But till then, if you can, I mean, that's the best approach, of course.
Yeah, they want to know if gene therapy is applicable even for nonsense mutations too.
Yeah,
It is
anybody, as I said, except deletion in 8 and 9.
Everyone else is.
Yeah.
Yeah, Anita, if you want to just convey something.
Hello, everyone. Dr. Vivek's the person whom we are contacting, Mr. Rajan, he is not doing well. That's why I am answering this question. There was a question that how can we go to UAE to avail this? So the main part of that, Dr. Vivek only covered.
Yeah.
Is this Rajan sound?
So
No,
I think
Dr. Vivek is
so what is happening at the moment, after 11 days, many parents are coming just to test for the AAVrh74 antibodies. And that just gives them the hope or the eligibility criteria. If the child is negative, then they know that, the child is eligible for that. What they do is they get a letter from me saying that the child is eligible for eligibility, and that letter is then used to raise the funds. That's one of the reasons why they come. Of course, I have to repeat the antibodies when they come actually for the gene therapy. But at the moment, more influx of the patient is for that reason. Assessment, functional scoring, guidance, antibody testing. Then they go back, start raising the fund. Once the fund is raised, then they contact us. Mr. Rajan is the point of contact. We have the email. I think we can provide the email to all of you later. And then
I
they
have
contact.
already shared in the chat,
Yeah.
Doctor. I have already
Then
shared
they
in the chat.
contact. So, I mean, any query, you can just contact us and then they will assist. Made before visa, accommodation, any query. If it's clinical, I answer that. It passed on to me. If it's something logistic, he takes care of that.
Yeah, Rajan has sent me the stepwise. I'll just go
Yeah.
through that. Everyone, please listen carefully. Okay. Some part doctor has already covered, but I'm just going through it. Okay. Step 1 is parent has to fill a DMD questionnaire form and send mail to DXB that I have shared in the chat, but again I'm reading it. DXB Medical Care Travel at asterdmhealthcare.com. Then step 2 is once the form is received along with the DMD genetic report, Dr. Vivek will approve to give quotation. Then step 3 is doctor's team members will issue the quotation for Elvidis infusion service and also AAVrh74 antibody test package. Then the next step number 4 is AAVrh74 antibody test is optional and is suggested for parents who are planning to do fundraising. Because if in case AAVrh74 comes positive, then child may not be eligible for Elvidis and the fundraised money will go waste. So then step number 5, Medicare hospital will offer end-to-end support from providing and guidance for visa, hotel booking, complimentary hotel to hospital shuttle service. Once funds are raised, parent has to inform their preparedness and Medicare or Dr. Vivek team will take care of everything. Duration of stay in Dubai is about 3 months. Number of nights to spend in the hospital is just 1. Rest of 89 days will be serviced apartment where they will have to come and go for consultations and tests. In this, one thing I have to add is one day the doctor is taking a rest. The 89 days you can stay either in the hotel or if you have any relatives or friends, you can stay there also. And the budget part, apart from the treatment, you will have to go for the living expenses in Dubai. And living expenses in Dubai, with my experience, it will come around 10,000 dirhams minimum. If you are having any relatives staying there, then the rent and the utilities that you can save. But then also around 10,000 monthly you will have to take care. Then telephone is there. What the hospital provide is airport to hotel pickup will be there. Hotel to hospital shuttle services for 3 months. Whenever you have to go to the hospital, shuttle service will be provided. Then shuttle service is free for external appointments outside of Medcare, if any. That depends on the child's condition and all. Then translator services is provided. This is what it is provided. These steps we will post it. If anyone wants to go through it again, you can go through. The email address also we are posting it. Now I have posted it in the chat. I will be posting it in our groups also. So if anyone wants to get more details, you can go through this. So that is the brief.
Thank
Okay.
you. Thank you.
Yeah.
I just have a couple of questions, doctor, if time permits.
Yeah.
Is gene therapy or exon skipping beneficial for BMD, Becker muscular dystrophy?
Anyone, as I said, I know we haven't gone into clinical part, but any mutation, yes. So the eligibility is based on the mutation than the clinical picture. Of course, they are less symptomatic, so they're more beneficial. As I said earlier, we give more the child is asymptomatic, better is the outcome. If that's the kind of principle I briefly can explain.
What is the cost of the antibiotics test? I mean, roughly, approximately.
Antibody test.
Sorry, not antibiotics. I'm sorry.
The AAV RH74. We're doing it complementary, those who are coming to, because they're all the way coming from there. I think we're not just doing it on its own, because I need to assess the eligibility and all. So there's a cost involved, the hospital cost for assessment, the physiotherapy and all, which I think the Rajan will provide the cost, and the antibody test is included in that kind of package. I think he has developed some package for assessment.
Yes, I just wanted to add in this. One parent who had contacted Rajan, and he had got a code. In that, it is mentioned around 9,000 dirhams. Some parents have got the code and shared with us. So if you go through the old chats in our group, you will get one code. You can see the code.
Or
And
I'll
you
ask
can now
Rajan to
mail it to
connect with
doctor.
you later. Yeah.
Sorry. Yeah.
No, I was just
You
saying I
can,
can ask Mr. Rajan to connect with you later.
Yeah,
no, I have already shared
Okay.
Rajan's mail. You can mail it to Rajan. Please.
Sure.
Doctor, any idea of how soon the gene therapy will be available outside of the US and the Middle East? Any idea about it?
Gosh, I really don't know the answer. It's more of a political and a lot of other issues, how you bring the gene therapy to country. So it depends very country specific rules and laws and regulations. It's nothing to do. I mean, of course, India has pediatric neurologists and they can do that. But the logistic part is very tricky, doing the antibody test, because the antibody test goes to US. We have to arrange all the couriers and maintain the temperature. The drug comes in -60 degrees. There are a lot of logistical part. So the center readiness is something Roche has always, because we were already giving the gene therapy in SMA. That's why they chose us. But I think India, they're giving SMA under GMAP. Even the Zolgensma is not commercially licensed product there in India. That's why they're getting it under GMAP, the free drug therapy. So honestly, I don't know when, because it's more to do at higher level, more of political will when to do that.
Thank you, doctor. Thank you for your time, and thank you for this wonderful interactive session. I'm sure all of us have gained a lot of insights and knowledge into this whole gene therapy. We really, really appreciate and your valuable time, sir.
Thank
Rama,
you. Thank you.
any remarks, Rama?
I will just thank Rajan also. From last 2-3 weeks, we have been talking continuously. Thank you, Rajan, for connecting to Dr. Vivek. It was nice talking. And some people have asked the 10,000. What I said is rupees or dirhams. It is dirhams. It will be 10,000 rupees dirhams. You will means dirhams. You will be having a normal life. That's a special. If you are like in between when you are getting time, if you want to go and visit places and spend, then it will go above. This is a normal lifestyle. 10,000 dirhams you will need there. Okay. Yeah. Thank you, Dr. Vivek, and thank you, Rajan. I hope he is listening.
Thanks.
So thank you so much.
Thank you all for joining.
With all other queries, we will be connecting to you again. We will disturb you
Sure.
again.
Thank
Okay.
you.
Thank you so
Anytime.
much.
Anytime. Thank you.
Thank you, everyone who joined. And any queries, please mail or connect to us. Thank you.
Yeah. Thank you, Anita ji. Thank you, Sharda ma'am. Thanks a ton for all joining.
Many questions were specific and and repetitive, so it was not